So today we're talking about dementia and primary care, and the real thrust of this is thinking about implementation of dementia care within our practices. This is supported by a grant from the Office of Aging and Disability Services. We also have support in terms of our food from Maine General Health, and I think we should have an enjoyable day. We have a number of organizations represented here by different people, including the Alzheimer's Association. We have folks from our area agencies on aging, also the Office of Aging and Disability Services. For those practices that are going to be engaged in implementation, the Muskie Center is also doing some work for us on evaluation, and a couple of people here, Mark Richards and Lindsay Smith, could you just kind of raise your hands so people might know who you are? They may be contacting you in terms of the practices. They're up way in the back there, and but they're part of the team that is doing this work. Also, Lunder Deneen, which sponsors the website, and I have a couple of slides about them. MemoryWorks, which is very involved in memory cafes, opportunities for persons with dementia to get together. And then we also have two statewide organizations related to geriatrics and gerontology, the Dirigo Maine Geriatric Society, which is an affiliate of the American Geriatric Society, and that organization really has a strong focus on training and reaching out to other providers other than geriatricians in terms of geriatric care. And then the Maine Gerontological Society, which has been here in the state for approximately 25 years. And that organization provides a great linkage with a breadth of people involved in gerontology, and as well as the University of New England and the University of Maine. So a lot of opportunity for interesting conversation. Lunder Deneen is a health education alliance working with Mass General. Their vision is improving overall health of Maine residents, and they really have a breadth of outreach, but they have also helped us to set up a web page and website which is specifically directed to dementia care. And so I'm going to just invite Christine Merchant, who's filling in for Romaine, for a welcome from the Office of Aging and Disability Services.
Gary Walcott was originally here to say hello and greetings. He's meeting with the governor this morning. Romaine, my supervisor, the manager of our aging unit, I'm not Romaine, and she's lost her voice. She should be here a little bit later. So it comes to me, and I'm thrilled because I'm actually the grant manager. I'm intimately involved with this grant from the beginning and with many of you directly or indirectly. So I'm thrilled to welcome you here this morning. I'm so excited to be a part of this, this event today. And today's symposium will focus on one of the most significant systems that this grant is designed to expand our dementia capability in the area of physician practices and primary care in the state of Maine. And we know that people are challenged in getting a diagnosis, and we hear many concerns from families about getting a diagnosis and then being told to come back in 6 months with no additional support in the interim. By the end of today, it's our intention that you will not only feel much more confident and knowledgeable about diagnosis, treatment, assessment, and resources, but particularly resources, that's not the main focus, but resources available to you in the community to actually make a difference in that gap, of which this grant is actually looking at many gaps in the system of dementia capability in the state of Maine. Just a couple brief other things that this grant, as a systems grant, is designed to target. Ask me later in the day if you'd like more information. One is a basic online free dementia training, and I have thousands of these brand new pretty cards printed. They're out in our table. Please pick up many to take with you. There's other continuing education courses that are also free, online, interactive, and wonderful. Dementia Basics is the one that I want to highlight. It's designed specifically for personal support workers, but we are also recommending it to families and caregivers who are just desperate for some basic information. You can get it anytime in the middle of the night when you're up when you're up, and you can come back and forth to pick it up anytime. Additionally, we're working with the area agencies on aging to develop a standard protocol to help identify people themselves or caring for someone with a possible dementia, and and talk to me about that later too if you're interested. And I'm just going to give you a sneak preview of a brain health initiative that will be rolling out in the next month and a half to 2 months, where you will be, so you could kind of be looking for TV and radio spots that we think are very exciting, and they are going to be encouraged to be referred to you. So this is really urgent and important that we're all coming together at the same time. Lastly, you may have heard about the Savvy Caregiver training for caregivers of people still living at home with dementia. We've got schedules out and back. You can pick that up. So most importantly for today, I want to acknowledge, appreciate, and thank Cliff Singer, Roger Renfrew for the outstanding leadership that they have provided as a stakeholder from the beginning. We started meeting over a year ago to just go, gosh, you know, what are we going to do? There's so many needs. And to have this idea come from a just like this is important and it's such a need to today is, I can't even tell you. As a state employee these days, to have this kind of satisfaction of something actually happening that is this important, that is bringing this kind of diverse group of people together is really rewarding. And we all need rewards of satisfaction in our jobs, so I'm thrilled to be letting you know that I'm having such excitement today, I can't even tell you. So come and meet us throughout the day. Romaine Turin, my supervisor, is here, and she would be happy to talk with you throughout the day. Please come up and ask us questions. Thank you, welcome again, and take it away.
Thanks.
All right.
So Christine's comments just point out how important sort of team and community are for taking care of patients with dementia, and the breadth of this grant really helps to promulgate that. So I just wanted to quickly go over what's in your packet. So on the right side you have the schedule. You have that all-important evaluation sheet, which needs to be completed, and we'll ask you to hand in at the end. We have copies of the various talks. On the left-hand side, a number of resources. I just put for those who are here in this area, I put in the hearing loss and hearing aid services, but I wanted that in here to remind all of us how important hearing loss can be in relationship to dementia or confusing us in terms of the diagnosis. I will be speaking to the Alzheimer's Association app, and you can pick up cards for that in the background at the Alzheimer's table. There are a number of links here for varying resources, and the Lunder-Dineen website will also be putting up these links, so those resources will be available to you. There are some papers on the ACOV indicators for dementia care and their overlap with other organizations looking at indicators for dementia care, and I will be speaking to those, so you'll have a sense of them shortly. I also have some tools that are hopefully of help. And then finally, we have, I also have a QI proposed project and a number of other resources, but a list of people who are attendees and how to be in touch with them. We also have some information on the Motivate project by Lunder-Dineen, which is about dental health. Nancy Rushton, one of the attendees here, is part of that project. And so lots of information there that hopefully will be useful to you. So again, this is really a serious attempt to try to think about how each of these elements can fit into your practice. And we're very interested in hearing from you about both knowledge and support needs. People who are in practices that are not affiliated with either of the institutions but are interested in the embedding process and working on the QI, please be in touch with me. We have emails here for myself, Cliff Singer at Eastern Maine, and Heidi Wireman from Maine Medical Center. So feel free to contact any of us, and those emails are there. I think we went over the packet. So disclosure, neither I nor any of the speakers have any real or apparent conflicts of interest that may have a direct bearing on the subject matter of this CME program. So our goals are that you will identify aspects of dementia care which are supported by national quality indicators. You will identify opportunities and approaches to improve dementia care within your practice, and then identify methods to optimize team function within the practice and community. So for us, we want to be implementing a standardized approach to dementia care and then linking that to a quality improvement process. And again, on one of those sheets, you can see the overlap with PQRS indicators. Those are the Physician Quality Reporting System, as well as anticipated NQF, or National Quality Forum indicators, for defining dementia-capable practices. We also want to implement a QI process focusing. The ACOV indicators have 16 indicators that apply to clinical practices. We're really focusing on 3 of them, which is early detection or screening, further workup and evaluation, and then referral to community resources. So that's the focus of the QI process. There is a state plan for Alzheimer's disease and related dementias, and there's the URL. If you just Google Maine State Plan for Alzheimer's, you'll catch that, and that's an important piece of work with some resources in it. So why is this something we need to tackle at this point in time? Why is this important? Well, number one is the baby boomer effect. Maine is the oldest state by median age. We also have the largest percentage of baby boomers. So, and dementia is associated with aging. 90% of cases are greater than 74 years old, and both incidence and prevalence go up with age. It complicates the management of other illnesses. So Medicare costs of care triple with the diagnosis of dementia. It's associated with increased length of stay, readmissions. It's under-recognized and under-managed. So up to 50% of cases are not recognized. More than 50% of cases at diagnosis are moderate or severe in terms of their progression. It has a huge impact on caregivers in terms of personal burden, financial burden, and health. And who's going to provide geriatric care? So there are 7,000 boarded geriatricians in the United States. That's 2004 data. That is not improved, and to some extent has been decreasing over the past few years. There are about 12,000 neurologists, 2,500 geriatric psychiatrists, and logarithmically more primary care providers. I use the term primary care specialist because we have a particular specialty in terms of that balancing of multiple chronic illnesses in our patients, and generally the specialists are not going to do that work. So right now, primary care specialists provide 80% of chronic care of older Americans. The challenge in the office is you've got multiple chronic illnesses, you've got geriatric syndromes, and you also have social issues. The American Geriatric Society in May of 2012 introduced their program called 3 or More, or 3+. And again, this was based on the fact that once you go into Medicare, over 50% of Medicare patients or adults covered by Medicare have 3 or more chronic conditions. Almost all of the existing guidelines that we have for care really have a single disease focus and have very little evidence on elderly. So their initiative is to develop guiding principles for the management of the older adult with comorbid conditions. The reality of this is even more complex. So in November of 2012, there was a VA study published, and they were looking at what are the combinations of 3 diseases. They were just listing all these triplets. And of course, they've got this huge database that they can mine. And they were the usual kind of stuff you would expect. I mean, you've got COPD, congestive heart failure, diabetes, hypertension, hyperlipidemia, et cetera. But in the 15 most common triplets, the mean number of conditions ranged from 7 to 9. And this was, I read that article and I said, finally, somebody in academics understands my day-to-day. I mean, this is what we deal with. So the complexity of an office visit deals with 3+ equals 9+, chronic illnesses, geriatric syndromes, social issues, and how are we going to deal with it? Well, to some extent, you need a structured team approach to do this. And the team includes all the members of your office team who interact with patients or, in small communities, live in the community. I'm sure all of us have had that experience of somebody from our office, one of the staff saying, you know, so-and-so seems to be having problems driving, or we've noticed they're not getting their garbage out or something. I mean, that kind of feedback, especially in small communities, is very common. It generally requires defined roles, training, and supportive systems. And the team we need extends well beyond our office. So if I see a patient in my office for half an hour once a month, which is a fair amount of visits, that is less than 1/1000th of their life. So hopefully the work I do in my office is important, but it's really much of the care of these patients is not occurring in my office. So structure is the key to implementing standardization. It also allows us the opportunity to measurement for quality improvement. And that can be very simple. When we first started working with this kind of approach in my office, after about 6 months, we just kind of sat down and said, well, how are we just kind of going through these indicators, and we're going, well, how are we doing connecting with community resources? We're not. So it was fairly easy to just make a next step. So again, that standardization and structure allow you to ask those kinds of questions. Again, PQRS has dementia-specific CMS indicators if you're interested in using that as part of your quality reporting, and we talked about the dementia-capable practice concept. The ACOVE is assessing care of the vulnerable elderly, and it's a series of indicators of care for vulnerable elderly patients, which we should all meet, is their definition. In reality, this is very aspirational, and I'll speak to that. There are 17 indicators for dementia, one of which applies only to the hospital setting. And the structure of these is if a vulnerable elderly is new to a primary care practice, then there should be a documented assessment of cognitive ability and functional status. And so there are 16 of these that apply to the outpatient arena. These were published in the Journal of the American Geriatrics Society in 2005. There are a number of indicators that are not addressed, such as specifics of medication therapy, staging of dementia, dental health. And so how do we do with this? So this was looking at, the first article was looking at a selected group of primary care specialists in North Carolina, and use of the mini-cog, only 21%. Another article in looking at patients who had been diagnosed with dementia, and anywhere from 4 to 60%. So almost as anywhere 40 to 95% had not undergone formal mental status examination. Another article actually looking at Maine physicians, referring to our area agencies on aging only about 44% of the time, and a moderate sense of unfamiliarity with community resources. So at the UCLA Academic Geriatrics Clinic, these are people who are involved in the development of the ACOB indicators. They found less than 40% compliance with these processes of care in their academic geriatric clinic. So this is challenging. Interestingly, they were not doing any better than the performance of general primary care specialists in the community. Introducing a nurse practitioner who was tasked with addressing those indicators of geriatric care brought about a 20% improvement in those numbers. David Rubin, who was one of the developers of this and is the chief of geriatrics at UCLA, found up to 50% improvement with a nurse practitioner in community-based care for geriatric syndromes. In dementia care, the absolute benefit went up 21%, but again, you can see we're not nailing this, and it's challenging work. So it's still hard work. This is a recent article in looking at fall measures in primary care, and there's a PQRS bundle on falls, and they actually implemented that. They improved the processes, although they interestingly did not improve or did not make a great deal of progress in engaging patients in ongoing fall programs to improve their gait and balance. But there were no changes in falls requiring hospitalization, no change in hospital costs, and they actually dropped it as a PQRS reporting bundle. They switched to something that was going to be easier to do and succeed at. So it's hard work, but it's an opportunity for us to learn and an opportunity for us to learn together.